Hello, you're welcome to this year's 2025 edition of the West African College of Physicians revision course. I'm Dr. Ohaeri. My lecture is on phenomenology, psychopathology, and history of psychiatry. Since it is impossible to present these three topics in the 1 hour allotted, what I've done is to painstakingly put together a fuller presentation in the slides in a form of mini textbooks with emphasis on psychopathology. But I've also articulated the essential elements of the lecture on the history of psychiatry and phenomenology that you require. It is your responsibility to find time to patiently read through and thereby achieve the objectives of the lecture. And also deserve the effort that I've put into making you to be modern, knowledgeable psychiatrists in the field of psychopathology. As a foundational discipline of psychiatry, psychopathology should be a clinical discipline that provides the clinician a foothold to clarify the biological, psychological, and social underpinnings of mental disorders for effective treatment. Now, how should we teach psychopathology at the postgraduate level? Should it just be what we have in the traditional textbooks, being more like a glossary of abnormal mental experiences, as we find in the books? And the current one that's of my interest really is symptoms in the mind by my friend Femi Oyebode. But when we were residents, we also read psychopathology by Fish. So I prefer that, following the example of physical medicine, an understanding of these abnormal mental states within the wider context of the implications for etiology, investigation, diagnosis, and that's how we should be looking at psychopathology. In other words, as a multidisciplinary topic, I choose this perspective in what I've called the boundaries of psychopathology. That is, as a foundational discipline of psychiatry, around which all aspects of the field of psychiatry revolve. So that the objective has to be a panoramic view that helps students to factor the knowledge of psychopathology into a quest to understand as much of the totality of mental disorders as possible in order to enable us offer effective treatments. And this is my approach. And this approach, we are going to see in a figure which I will show you as the boundaries of psychopathology. But if you look at the objectives of my lecture, you will actually get a lot. And I'm saying this because we have only 1 hour for this presentation. So if you just look at the objectives alone, you get a lot of knowledge. So of interest, in particular, we shall highlight the evolution of interest or subspecializations in the science of psychopathology, from phenomenology of Edmund Husserl and psychoanalysis through descriptive general psychopathology of Carl Jaspers and classifications to the diagnostic criteria that we have today and psychiatric epidemiology. And now we have to talk about psychopathology, cognitive neuroscience, and precision medicines. They are coming in using the ideas of polygenic risk scores, neuroimaging, and artificial intelligence. Let's see how we can broach our topic of psychopathology to see that the concept, the idea of psychopathology is really the underlying factor in all these. All these are just attempts to explain psychopathology from various backgrounds and technologies. We should also highlight the evolution of the biology of psychopathology and consciousness from neurochemistry, that is the biogenic mean hypothesis, through neuroanatomy to neurophysiology. And here we shall lay emphasis on the new knowledge, what we call the triple network model, the default mode network, the salience network, central executive network. This idea is now transcending, or more or less, let's say, evolving from the idea of the biogenic mean hypothesis, and ultimately is aimed at personalized diagnosis and treatment to transcend the current one-size-fits-all in nosology and treatment. So we shall lay some emphasis on this. So these are the kind of things that we should have been able to talk about in this lecture. But as I said, it's a 1 hour, so we just have to read the details in the slides. So the definition of psychopathology dates back to 1913 from the work of Karl Jaspers, who, as we know, was primarily a philosopher on phenomenology, and then did his MD in this topic. And that book he wrote has continued to inspire generations of psychiatrists. How do we currently define psychopathology? This discipline can be understood as an in-depth study of problems related to mental health. And as I was saying in the idea of the panoramic view, that just like pathology is the study of the nature of disease, including causes, development, and outcomes, psychopathology is the study of the same concepts within the realm of mental health or illness. And that is what our conceptual framework is about. In this way, psychopathology is all about exploring problems related to mental health, that is, how to understand them, how to classify them, and how to fix them. In other words, psychopathology extends from research to treatment and covers every step in between. So what we'll do now is to understand the figure, which I'm going to show in the next slide or so, about what I call the boundaries of psychopathology, or the panoramic view. You are going to see that it contains the essential elements that you need to make sense of when you elicit the symptoms of psychopathology. To me, this model that I presented is really a fulfillment of Freud when he talked about the diagram that explained the basis of psychopathology. And also Eric Kandel, in his book, he was a Nobel Prize winner, of course, as you know, the second psychiatrist to do so. In his book, In Search of Memory, which is a highly interesting book to read. So this is the major point of this presentation, this diagram. You can't find it anywhere except in this my presentation. What's he saying? Look at the 6 domains represented by the 6 lines you see. You see the horizontal one, the vertical one at the center, which points at the central portion of this figure. You see that it's dealing with the traditional aspects of psychopathology, whereby we describe the symptoms. So you see at the very center where you see diagnostic criteria of today, you see that the most central figure vertical there, talking about abnormalities of thought, that's delusions, abnormalities of perceptions, hallucinations, mood states, somatization, premorbid personality as a trace, as risk factors. We usually don't talk about this when we talk about psychopathology, but we know that premorbid traits, when you have a combination of high neuroticism and low extraversion, you are at greatest risk for mental disorders. The neurosis, introduced by the Scottish physician Cullen, and then we look at the way psychologists, for instance, talk about anxiety and depression as a tripartite model. Um, a lot of these ideas are, of course, included in same psychopathology. To the right of that center, that central facet, you have psychopathology of organic mental states, especially epilepsy, the deja vu, jamais vu, and addiction. Now, I'm going to put some point about addiction psychopathology. One, in the program that I've seen for this lecture about addiction, is really mainly about epidemiology and description, but nothing about biology. And again, also, if you look into the usual textbooks of psychiatry, there is usually a silence on what I call addiction psychopathology. So I'll just give 3 slides. I think I have 3 slides in this presentation. But we then talk about rare syndromes, which Femi Oyebode has described in his new book. But I have actually brought out a list of 25 of them from Dr. Srinam's presentation. So we'll talk a bit about them. Now, to the left side of that central box, you see psychopathology of consciousness. That's like the realization, the personalization, and co. Whenever we have these symptoms, we think of doing EEG. Now, let's go on the right side of the figure. On the right side, the right column, you have the psychiatric nosology. We shall, or rather, we have slides that give you some details about changes in the transition from ICD-10 to 11, and also from DSM-4 to DSM-5, because there are controversies on these issues and how the postgraduate student can understand in these controversies, and then the limitations of the current systems, especially that they are categorical, and then the DSM-5 tried to get at this by putting some dimensional kind of classification. And the hopes of the research domain criteria. So, how do we distinguish a category of mental disorders from the others? And also the paradox of how do we group categories of problems that belong together? You know, for instance, when we say internalizing kind of diagnosis versus externalizing ones, how do we put it together? This is in the 11 criteria put forth by Gavin Andrews and his colleagues. So to the extreme right column, you have psychiatric epidemiology. Now, this is a more familiar area for people, but what's not familiar for students is about instrumentation. I have made a list of the various instruments and actually found a way of classifying them. The students should be very conversant with the use of these instruments. So we have diagnostic instruments. How do we differentiate them from screening instruments? And then what do we mean by cross-sectional as opposed to a longitudinal follow-up study? How do we quantify outcomes? You know, using scales like the brief psychiatric rating scale, Anderson's scales, positive and negative syndrome, and all that. Then we look into personality and quality of life issues, self-esteem, all that, you know, what to call patient-centered outcomes, and caregiver measures of burden and social support. These are the kind of instruments that we should be aware of and we should be able to use when we are rating psychopathology. So, to the left side, the first column, on the left side of the center, we find what I call the new psychopathology. because the traditional books are silent again on neurocognition. But what I've done for this class is to bring together the section from the DSM-5 that gives us the 6 domains for understanding neurocognition, and is listed there. And also the attempt by the Americans in the Matrix program to bring forth measurable cognitive impairments that have links to biological abnormalities. So the kind of cognitive abnormalities you should be looking forward to. And of course, I will also touch, or the slides will touch on, the kind of drugs that we use and the neurobiology of cognition. That is, what are the various neurotransmitters that are in problem, and the anatomical disposition, and the use of drugs for cognitive enhancement, Provigil for instance, and the idea of cognitive remediation. And to the left part, again, the biology of psychopathology. This is a very neglected area in our teaching in psychiatry in Nigeria. And as some very great fellow has said, really also in the world. So we have to understand the idea of psychiatric genomics from the fact that we used to deal with candidate genes, you know, before the Human Genome Project, which psychiatrists should know about, because it has very great relevance for us. And that has now given us the idea of using what we call single nucleotide polymorphisms to show that there's a lot of cross-disorder correlation. That is, many disorders, schizophrenia, autism, bipolar disorder, they actually share genes a lot. And of course, anxiety and depression. This is a way to explain comorbidity. And then the idea of the polygenic risk score, which is really trying to rescue us from the fact that we cannot do a test to determine that somebody, a biological test to determine that somebody has schizophrenia, for instance. So this idea of polygenic risk score is leading us in that direction. And then neuroimaging and co, which have helped us to bring, for instance, dementia into the column of biology now, not just epidemiology or neuropsychological assessment. That has helped us a lot. So the psychopathology of these and the psychopathophysiology, as I've said, using the biogenic amine hypothesis, we shall give some view of it, and the transition to the glutamate and serotonin hypothesis, and the idea of schizophrenia as an abnormality of aberrant salience, and the influence of inflammatory processes. Then to the extreme left, we have notable outcome studies, like naturalistic studies, starting from the WHO IPSS, in which Nigeria was at Ibadan, was a center. And the other studies, the intervention studies, the phase 4 studies, Katie, Cutlass, and co, that have helped us to really, these days, define our treatment plans, when we talk about our treatment goals and how to get there. Okay, so in other words, this diagram is really about that if you have, for instance, a test from the chemical pathology lab that tells you this is the way you see a liver function test, for instance. Now you start thinking about things that could go wrong, in what way they could go wrong, areas that are affected. That's what this kind of slide is telling you, that when you have a psychopathology symptom, you don't just stay there. you look at the various areas that will be important to be assessed and looked into. So descriptive psychopathology is a fundamental professional skill of the psychiatrist. It is possibly the only skill unique to the psychiatrist. Its accurate application involves the deployment of empathy and understanding, which is from the field of phenomenology. And then Professor Lataura told us about the 3 Ps, or the psychiatrist has to understand: psychopathology, psychopharmacology, and psychotherapy. So this is more like my lecture outline. It's really like educating you about areas. Actually, there are considerable details in this presentation in the slides that will come later, but you have to read through them. Understanding this lecture outline really is like, as I said, a mini textbook. So these are the kind of things that I'm supposed to tell you about, but I'm not able to do that. Definition of psychopathology terms using Anderson scale for negative and positive symptoms. This is a brilliant glossary, and when you know it, then you know psychopathology really. Please look this up. You can also see them in the glossary of PSC or SCAN, that is Schedule for Clinical Assessment in Neuropsychiatry. These are very useful teachers, for the, and you also know about the various ways of looking at schizophrenia, down to Tim Krau's highly popular type 1 and type 2 schizophrenia. Okay, so there you are, how you define positive and negative symptoms. What do you mean syndromes or symptoms, whichever one you call them. And the evolution of the dopamine theory. And then let's talk about phenomenology a bit as a philosophical discipline founded by Edmund Husserl and his group. So what we can just say is that it's a school or system of philosophy that just asks you, what is it like to have sensations of various kinds? So they are studying conscious experience as experience from the subjective or first-person point of view. It is to be distinguished from other fields of philosophy. So in psychology, we study normal mental appearance or experiences, which we call phenomena like hearing and vision. Psychopathology is the study of abnormal mental states. Okay, so we have to mention the vital contribution of Karl Jaspers, who, as I said, was a philosopher, but did his study on MD on psychopathology. So psychopathology is a discipline, as I said. The most important work, you could say historically really, was from Karl Jaspers. The study of symptoms of mental disorders, psychic distress, and abnormal maladaptive behavior. So we have the joys of the psychopathologist, that you can understand the suffering or mental suffering of your fellow human beings. So we are asked to focus on descriptive psychopathology. Just say, what is this person complaining of? I feel depressed, or I feel very happy, or what? The dynamic aspect of it, the books tell us to be more silent because they can be value-based. And that's why the ICD-10, for instance, says this book is atheoretical, because we say that once you start finding reasons on your own, you start interpreting based on your value system. So, so psychodynamics is really put down these days. I lament this situation because my teachers were great dynamics psychopathologists, and They were excellent fellows. Psychopathology of rare syndromes, I've put forth 25 of them. There are about 25 of them, as I said. What we're going to do really is to focus on just 3 of them. That is Capgras syndrome. We're going to focus on the opposite, which is Frigoli, and then we'll also talk about the syndrome of subjective doubles. What's the difference between these 3? Capgras, Frigoli, and the syndrome of doubles, or what the Germans call doppelganger. So, if in Capgras you think that somebody that you know is being replaced by another person. So that's number 1. In the Frigoli, you think that this other person is taking on many more forms. It's just like you put up his clothes and changes to another one, changes to multiple persons. That's Frigoli. Whereas in the syndrome of subjective double, you are just thinking that you yourself are the person, you are the one who has changed to another person. So we have to be able to distinguish those 3 features. I have given more thought or more space to Charles Bonnet syndrome because I saw it in one of the exam papers, so I thought we should do. But I have given you the basic ideas here. Please read it up. The basic thing really is that it causes a person whose vision has started to deteriorate to see things that are not real. That's the basic thing. In other words, it's not really responsive to our traditional antipsychotic drugs. It's not really responsive to that. Rather, there's a new drug that acts more on serotonin, pimavanserin, which is used for people who have Parkinson's disease and have dementia. So it's possible that it could have effect. We don't have that drug to have tried. So then you reassure these people. Please see that you read up on these points that I brought up for you. So you advise them, you reassure them, and they can take personal measures that they themselves have found to work for them. So now we go into more biology, what I call psychopathology. As I've said, there's an attempt to beat down on the idea of psychodynamics. But we can do psychodynamics from the point of view of biology. So the biogenic mean hypothesis is a standpoint, is a foundation for that, or the dopamine theory of psychosis is the most successful of these ideas. And modern psychiatrists need to be conversant with its evolution, as in the books by Oliver Howes and Kshitish Kapoor. These are very brilliant human beings coming from the Institute of Psychiatry. I've given you the references. Please read up this. The basic idea is that there should be an understanding of the neurobiological basis of psychopathology based on the grounding on the knowledge of neurotransmitters and neuroreceptors that are thought to mediate the psychopathological experience. So you have the biogenic amines, catecholamines, and so, as I've listed them there, and 5-hydroxytryptamine, the serotonin group, and histamine. Then there are the new ones, the gamma-aminobutyric acid. New ones are much more newly discovered. And the glutamate was the last to join. Glutamate is the commonest neuron in the brain, and it's excitatory, over 80% of neurons. And of course, you have to have a balance. That is the GABA, which is more like a restrainer. And it is the dynamics of these two that you find you having mental disorders. Okay. What was initially termed the biogenic amine hypothesis has now been broadened to include the glutamate hypothesis. As I said, is the most popular of these theories, the most successful really. And it has come down to the idea that dopamine is associated with psychosis through the salience network, while it undergoes addiction through the reward system. In other words, dopamine, when you come to serious or severe mental disorders, becomes the final common pathway. So the idea of salience is the fact that dopamine is in trouble and is the one that mediates salience. Salience, that means what you consider to be important, to pay attention to. So when it goes wrong, your perceptions, you don't get them right, and your thoughts too, you don't get them right. So you have hallucinations and or delusions. You also undergoes addiction because dopamine also is behind the idea of the reward system, which I'll give more details about this in later slide. So the salience network is triggered by the mesolimbic pathway, while the reward network system is triggered by the mesocortical and mesolimbic pathways. So this is dopamine synthesis. You have from tyrosine through dopa to dopamine. This diagram is important to me because it helped me to understand the effects of the new drugs that treat tardive dyskinesia, because those drugs are working on the circle you see on the right side of the diagram, the vesicular monoamine transporters. That's where those drugs are working on to treat tardive dyskinesia. So we'll look at this in this slide, where you find the lower diagram, pink in color. You see has the 5 dopamine neurotransmitters that have been described. You see that the extremes, D1 and D5, belong together, whereas the ones in the middle, D2 to D4, also belong together. So we have D1 type and D2 type. Up on top, you see this diagram, the vesicular monoamine transporters, as I've said. When you get the dopamine, they get involved in these clusters, and then they have to cross the synaptic space, and that's where things happen. The idea of schizophrenia and co was that the problem was in the postsynaptic area, whereas now the theory is that the problem is really in the presynaptic area. But that is a development of the theory that we are having. So these are diagrams that show you what we are talking about. This diagram is about telling you, look at the yellow lines. The yellow lines are telling you, they are pointing out to you the networks that I've talked about. From the midbrain, that's ventral tegmental area, to the cortex, that is a mesocortical pathway, the reward pathway too. From the midbrain to the nucleus accumbens, limbic system, that's mesolimbic, and then from the same area down to the corpus striatum, that's negrostriatal pathway. So these are 3 things to hold on to. This is a greater elaboration of that same diagram, just to help you understand. I like people to get an understanding in the practical manner. This is another elaboration of the same diagram. So, pathophysiology, an attempt to explain psychopathology by the medical model. So, as I said, the earliest attempt was by Freud's psychoanalytic theory, his diagram. And then we have all these new concepts. And then getting down to, as I said, Oliver Howes and Kshitij Kapoor and their evolution of dopamine theory. These are very brilliant works to read about. But I've given you a digest of that work in this slide. So if you read it, you see I've just explained a lot of it really. the fact that there is a dysfunction in the neurological systems controlled by dopamine, serotonin, and co. So that's the biogenic aiming hypothesis. For instance, that depression is associated with hypofunction along nerve channels mediated by monoamines, particularly noradrenaline and serotonin. It is not that there is excess of these um, um, receptors or even the substances themselves. No, but they are just lowered activity. And the way to account for it is in the subsequent slides that we shall present. And then the dopamine hypothesis of schizophrenia is that it's a model attributing symptoms of schizophrenia to a disturbed and hyperactive dopaminergic signal transaction. It's not that there is more dopamine necessary in the system, but there is hyperactivity. And how that hyperactivity comes on, involving mostly D2 receptors or D2 type receptors. We're going to show you in the subsequent slides. So this is the evolution, as I said in the paper by Oliver Howes and co. You can see that the way it evolves is saying that the final common pathway is dopaminergic dysregulation, and the symptoms we see are really because of there are downstream effects. The upstream effects are things happening way back to glutamate and GABA. We shall see this in a diagram later, the elephant diagram as they called it. So in the next slide, you are going to thank me for this, because I'm showing you the 3 neurochemical ways by which somebody can get psychotic. And that's it here. That you can see the column on the left is telling you a classical drugs that can induce psychosis that we know of, like we treat schizophrenia. So you have the psychostimulants, amphetamine for instance, or cocaine, and they work on the mesolimbic hyperdopaminergia system, and they lead to psychotic symptoms which are responsive to antipsychotics. And the problem is D2 antagonism. What we find now these days is that we have drugs that are acting not on the post-synaptic area, and not in the way that we know, because they are partial agonists. That means when there is too much dopamine, they beat it down. When there is too less, they try to excite it. Aripiprazole is the first in the class. Then we have cariprazine and lumateperone. I'm suggesting that if you read the mode of action of lumateperone, you get to know a lot, because that drug is really a poster drug for understanding the success or not of the dopamine hypothesis. Another way you can get psychotic is through the use of LSD and co, and that's acting on the serotonin system. As you can see in the column on the left, that you have on the right, rather, the column on the right, you have a pimavanserin which is acting on that system, and we use it for people with Parkinsonism who have psychotic symptoms. Another way you can get sick psychotically is ketamine, NMDA antagonism, which now releases glutamate to have glutamate excitotoxicity. And we shall see this in a diagram, and you get psychotic, usually with high level of visual hallucination. But the breaking news we have these days is something that's beyond the dopamine hypothesis. It's using the muscarinic and nicotinic antagonists as a site for finding an antipsychotic. And xanomeline is one in this, is a new drug, and we shall show a slide, we shall bring a slide to show you how it works. So this is the diagram. You can see the boxes below. On the right side, ventral tegmental area to ventral striatum, and that's how you get hallucinations and delusions. Whereas from the left side, substantia nigra to that's the dorsum, to the dorsum of the corpus striatum, and you get the extrapyramidal reactions. This is further detail on that, showing that the problem really, you can see the diagram on the top in black and blue. You see GABA, that's a major problem that goes wrong. Once it goes wrong, it releases glutamate to fire excessively, and now excites the dopamine, and that's what you see below. So you get ventral tegmental area exciting the dopamine, bad dopamine, so you get hallucinations and delusions as usual. And finally, this is more like a synthesis of the whole thing, that when the dysregulation of glutamate, it excites everybody, including the serotonin receptors, which are in the nuclear valve. The nuclear valve is a largest collection of serotonin right at the center of the pathway from the mesolimbic, from the mesencephalon down to medulla oblongata, right at the center of it. You find it if you look at the neuroanatomical diagram. I didn't want to bring one here so as not to confuse you further, but that's where it is. So you can see this is more like a composite diagram of the previous two diagrams above, to show you how everybody is now related. And this is a further this on that. So let's take a break and look at the psychopathology of addictions. What he's just saying here is that whatever drugs you take, they act either directly, like cocaine, to get a problem with dopamine, to regulate dopamine, and they cause their problem in that way. Or they can act indirectly, like alcohol, for instance, acting on GABA, but the effect is the same, whatever drugs you are taking. They are all included in this slide. These are the neuroreceptors that are involved. And this is the composite diagram that connects everybody. So whether indirectly you use alcohol and it disinhibits the GABA to cause problem, or heroin, or directly cocaine that blocks the function of these areas, or nicotine, or even cannabis acts in the same way to cause these problems. This is the kind of slide we use to educate our patients on the dangers of drug addiction. You see that the ones on the left show a healthy brain with good metabolism. When you then take cocaine or heroin or any of those things, you get hypometabolism, and it takes a long time to recover. So the one on the left, on that bottom side, you find the same, whether it's affecting the heart or whatever. So these are the dangers of drug addiction, and the subsequent figures show that when you follow up these patients over time, yes, they can recover if they are not taking the drugs. But if they are taking the drugs, they remain in the hypometabolic state. So the glutamate hypothesis, as I've said, is just that the problem is not primarily the dopamine. The dopamine is something downstream, and I'll show you in the elephant diagram. So there's excessive glutamate, because NMDA receptors in GABA are now underactive. So this is a paper really by Keshavan Nasrallah and Rajiv Tandon that showed us what to call the elephant diagram. On the right side of this elephant, you find the tail side, the symptoms that we notice for positive symptoms, negative symptoms, cognitive and affective symptoms. They are saying that these are downstream effects. The problem is at the head, the tusk on the left side, please, of this diagram, you find the tusk of the elephant, and that's where the problem is coming from. So multiple factors or multiple hits, whether genetic or environmental, they converge on the GABA and dysregulate the NMDA receptors, and then the glutamate is now free to do the damage it does. And that's what you can see drifting down towards the right side of the figure until you get to the problem with dopamine. That's just what this diagram is saying, that the symptoms we see are simply downstream effects of the impact on dopamine of dysregulation that had occurred upstream, especially with NMDA receptors. So these are diagrams showing you the various areas because you will have forgotten them. So me, I like looking at diagrams because they put these things in your brain. Okay? So the limbic system and all that. In case you don't have time, the default mode network, the triple network model that we've talked about, this is an advance now on the dopamine hypothesis. Now talking about the fact that a collection of neurons and their networks are really the things to worry about these days. So you have the default mode network, the salience network, and the executive network. These have been given details here. And starting from Alzheimer's, they help us to understand Alzheimer's dementia, Alzheimer's disease. So there are models of this network system in the various diseases, whether you are talking about Alzheimer's or schizophrenia or anything, they are all there. So the idea is that these things are leading us to what we call, the personalized medicine. So, for instance, all these are talking about giving you details about the networks. But the first one point I want to get to is to give you a diagram that summarizes them. You can see that the default mode network is consisting of the the medial prefrontal cortex, and then below that's the circles in green, the right lateral parietal, the left lateral parietal, and posterior cingulate. And then the salience network, you can see insular and the cingulate, anterior cingulate. So I will get to, these are the diagrams that show these areas so that you get properly informed. What is trying to say, okay, look at this attentional network. Every time we examine the patient, we ask about attention and concentration, and then see the areas that are involved so that you are more practically oriented when you examine your patients. So the central executive function, we know better, and all that. The salience network, yes, I have to just put it. This is a diagram that brings everybody together. Salience network on top, how it coordinates the work of the default mode and the central executive. What are we talking about these things? We are talking about them because we are looking into the future to see that ultimately our biogenic amine hypothesis is doing well. It will evolve, but it's evolved into this for the future. When I was a resident doctor in the early 80s, the biogenic amine hypothesis was evolving. When you become psychiatrists, big professors, bigger than me, this is what will be going on. personalized brain circuits, so that we are no longer looking at, let's say, if you have depression, we have to give you a citalopram. No, this kind of work with this network show that there could be at least 6 types of depression, and if you could map this person to the network that is particularly in trouble, you find a drug that goes for it. So it is not one size fits all. So I'm giving you an advance of what is going to happen, and I brought the papers down to you because they can be quite abstract for you to be able to understand. So you become really knowledgeable psychiatrists for the future, and hopefully one of you will be interested in taking up this work. Okay, so this is about it. That the dominant one-size-fits-all diagnostic approach leads to problems, So this is more the default mode network in depression and the default mode network in all sorts of situations. So the neurobiology of anxiety and depression, it also helps us to understand it. And even suicide, it helps us to understand the suicide circuit. So what's a mental disorder? As I've tried to, so we are leaving some biology alone and coming back to ordinary psychopathology, where we talk about distress, disability, durability, and exclusion criteria. These are the points that make up each of the diagnostic criteria in either the ICD or DSM. That's what you look for: distress, disability, durability, and then you have exclusion criteria. When you look at this, then you avoid the idea of checklist diagnosis. Okay? So what makes a symptom to be abnormal is as follows: the 4 areas. Psychosis, the idea of reality testing, and an ego function, if we want to go in that direction. So how do you define hallucinations and delusions, and the idea of systematized delusions, and all that? And I've talked about the rare syndromes that we talked about. So I talked about the rare, for instance, the rare otoscopic hallucinations, and what you mean, the ones where you see the person far off, extracampine hallucinations. All these type of things we can see in this slide if you read them in details. Okay, now we have to worry about the idea that these hallucinatory experiences are quite common in the general population, people who are not really psychotic. So you have to wonder, what's the meaning of hallucinations then? Because there are many people who have them and they are not as disorganized as to require treatment. These are papers that help you to understand these ideas. This is more like epidemiological thing, but a more focused, serious paper is this, to tell you, to help you to understand hallucinatory experiences that are occurring outside of frank psychosis. Okay, so these are the papers that help you. Psychopathology from YouTube, I have now taken time to call this. These are kind of things I read through, so that you don't have to go and start looking for them. I brought a collection out for you. It's your business now to look through these and understand them. Okay, so that makes life easier for you. Okay, so you have to talk about the neuroses that we talked about. It's usual not to talk about them when you talk about psychopathology, but we need to understand the idea of neuro. And the tripartite model of anxiety and depression by Clark and Wilson from America, that anxiety and depression, when you put the symptoms together, they cluster into 3 groups in factor analysis: symptoms that are specific to anxiety, symptoms that are specific to depression, and symptoms that are what we call general symptoms. And that's a brilliant paper by Clark and Watson. So I'll put together for you some practice questions to help you to bring these ideas together. Multi-axial system of classification, which we still ask you in the exam. This is it from the DSM and from the ICD. The DSM people have jettisoned it, but this is what they had in DSM-4. I believe is important, is useful. The idea of the gap score and so fast, and who does disability assessment schedule. So critique of the diagnostic criteria that they cannot address validity. They will help us to achieve reliability. So these are the major changes in the DSM-5 that you should know about. And the critique of the DSM-5 from the medical model, which I've hinted at already, the paradox of classification that we are looking for ways to distinguish one disorder from the other, whereas at the same time we are also looking how to put together categories that belong together. I mean, illnesses that belong together. So what we call internalizing and externalizing disorders. So the idea of distinguishing categories is starting from the work of Robbins and Goes, and that led us to what we have now as the diagnostic criteria. Whereas the criteria from Gavin Andrews and co., big giants of psychiatry, tell us how to pull together 11 criteria, very important to note. Okay, how do you distinguish psychiatric disorders? I mean, classification of psychopathological rating scales. I've classified them here for you. This is my own classification, and you won't find it in any book. Okay, and then the neurocognitive function disorders that you can see now from the DSM-5. I have pulled this together for you here, and it is in your own interest to read through. This is a highly educational slide. It helps you to understand neurocognition. I've taken time to put them down for you. Okay, so learning about executive function. This is my own idea to help people from my own experience. Memory, you can see the talk here, and the neurobiology of cognition. And then endophenotypes. What do we mean by endophenotypes? It has all been put together for you here. Okay, so neurocognitive dysfunctions as endophenotypes. I've attended a lecture that was just based on this, and that impressed me, by German, especially working memory as an endophenotype. You have to know. So diagnostic interview, you have to know you are looking at 3 levels: current mental state examination, usually in the past 1 month, 12 months mental state examination, and lifetime, that is ever have you had this. So whenever you are doing a mental state examination, examining these psychopathological symptoms, you have to look at the 3 levels of prevalence. Okay, so now the rating scales that I've said that you should know about. Positive symptoms are symptoms that are not usually present in the normal human experience, whereas negative symptoms represent a diminishing or positive of experiences which are normally part of our experience. Okay, so these are just papers that I put forth that I thought for those who are going to, this is for the students who are really very, who find this very interesting topic. Okay, these are really for the super students, in case you need to get updated. Okay, so the pathophysiology of anxiety and neurotic states, comorbidity. I'll give you this diagram. This is the most important diagram. So when they ask you, why is there so much comorbidity of anxiety and depression? The reason is primarily that there is a lot of sharing of genes. Look at column number 4 in this diagram. You find that the correlation between genes mediating anxiety and depression is 80%. So there are other reasons why you could talk about comorbidity of anxiety and depression, or even others, but the most important is this diagram, that you have a lot of cross disorder, sharing of genes. Okay, so the significance of hallucinations, yes, Then the dimensions of psychosis that I've told you that the DSM-5 is an advancement. You should know about these dimensions. Attenuated psychotic symptoms, these are important. So it is your job to read through and make use of the time, the effort I put into these slides. These are news digests. Then personality dimensions, which we rarely talk about in psychopathology. You should know, I've told you neuroticism, extraversion, and co. This is by Bienvenu, a Brazilian who has worked most on this. Okay? This is an important paper which if you read it, you understand about the premorbid personality and this idea of extraversion and neuroticism. Okay. These are papers I've put forward because in traditional books of psychopathology, you don't see people talking about these things. So I thought I should highlight them so that you know that the personality, for instance, it used to be in DSM-4, the axis 2, the idea of the premorbid personality. I'm not able to understand why they removed it in DSM-5. So this is some neurophysiology of consciousness for you. And then the neglect of somatization symptoms, again in traditional books of psychopathology. You should know about somatization symptoms and its new way of diagnosing it in DSM-5 and ICD-11. The history and philosophy of psychiatry, I can only ask you to look at the trends. Either you look at the development of psychiatric services or the development and understanding of types of psychopathology or classification, systems of classification, and contributions from behaviorism and attitude to psychiatry. All these are part of the large history of psychiatry. And then the contributions from the laboratories. So you now have, after the Human Genome Project, you have genomics. And then artificial intelligence, what we call AIology. And the fact that the amyloid technology is now helping us both to diagnose AD, Alzheimer's dementia, and also to treat it. So history of psychiatry, then I put forth the personalities. So you can look at history of psychiatry from various points of view. So you can use this type of questions to round up on your understanding of the history of psychiatry. The philosophy of psychiatry, I've also put forth some papers here, some ideas here, so as to help you. So these are the references. So what remains for me now, this is the one I told you is breaking news. Xanomeline trospium, the drug that is not dopaminergic and not serotonergic, is actually cholinergic and is being advanced as an antipsychotic. This is beyond the biogenic amine hypothesis. So it is a breaking news. Okay, so that's xanomeline trospium, the papers, which ordinarily you may not have time for. This is what the Americans or other parts of the other psychiatrists are doing to advance the idea of understanding our diagnosis of psychiatric disorders. So if I were to have a chance to develop the biology of psychopathology, this is the kind of course outline that I will have. This is of course for the future, but I'm putting it up for bright students who might remember me sometime, when they are talking about the biology of psychopathology in Nigeria, so you can use this as a point to now develop this course on the biology of psychopathology. I'm very interested in it. Thank you.